right. Thanks, everybody, for being here for the July Medicaid Client Voice Council meeting. This is a really exciting meeting because it's our new version that pairs with the Medicaid Advisory Committee that will meet for the first time this afternoon. Some of y'all will be in that meeting, too. But appreciate everybody who's here. We may have some folks online, and I know a couple members reached out and said they'd be joining us a little late. So we should have some additional folks here as the meeting goes on, but we're going to go ahead and jump in and get started. For those that don't know me, I'm Gavin Lesnick. I'm the Chief of Communications at DHS. I'm filling in just for today because Jason Peterson is out of state. He sends his regards and is going to be back at the next meeting. But we have a lot to talk about, so I want to go ahead and jump in. But first, just a couple ground rules and some new information. We do have a change in how we're able to interact with the virtual audience today. Previously, they had to text, and then Jason would relay that. We now have the ability to pipe them in over the speakers here. However, we have to ask them to unmute and then give them the ability to speak and then mute this room. So it may be a little bit awkward. I think we'll have some growing pains as we get used to it, but we will hopefully be able to use that as the meeting goes on. I will talk directly to them and say, hey, you are able to speak, and we'll listen to them, and then we can respond. So hopefully it'll work better than our previous setup, and we'll have that going forward. So we're excited about that. Just a couple reminders. When you're speaking in the room, I know we all can hear each other without the microphone, but please wait for the microphone to come to you. I'll bring it around. Otherwise, they can't hear on the online. We also realized as we set this meeting up, we did not put in any break. So assuming that we stay on time, we're going to try and take probably a 5 to 10 minute break between the two sessions. But I'll announce that so the folks online can follow too. I also have a little bit of a change in the lineup. Deputy Secretary Janet Mann is excited to be here, but she couldn't be here at the beginning of the meeting, so she'll come in at the end, and we'll have her speak to you all then. You may have seen a big announcement since we last met. Secretary Putnam, who you've met before, is leaving the agency this month, and Deputy Secretary Mann will become secretary. So we're really excited about that, and I know she's excited to speak to you all about the future and being in that role. With that, I'm going to go ahead, and I see Brandy got here just in time. I'm going to get the mic and let you make some opening.
Thank you. Apologize for my tardiness this morning, but 13-year-old daughter's in volleyball. It's been a crazy summer. Wanted to just welcome everybody. Thank everyone for being here. Looking forward to our discussions today and coming up with our proposals that we want to take to our first MAC meeting. Looking forward to that as well. I've had a few emails from some of our group, which is great to have some input, and so we're looking forward to sharing those things with you today. Thank you.
Thank you, Brandy. And Jennifer, would you like to say a few words?
I'm Jennifer Yeager, and I'm the vice chairman, and I'm also excited about the MAC meeting and some of the things that we can propose for that.
All right, thank you both. And yes, as a reminder, part of this meeting now will be going through those suggestions, and the council as a body determining which 3 to 5 to send on to the Medicaid Advisory Committee. My hope is we will just have a discussion and kind of settle on the handful, but if we need to do a vote, we can poll the room, and we can also poll any members who are online. I would ask the chair and co-chair if you all will kind of keep a running tally of what you think are the likely options, then we can present that again at the end just to remind folks. And with that, we will jump into our first discussion, which is really an overview of the provider-led Arkansas Shared Savings Entities, or as everybody knows them, the PASSes. We had a lot of suggestions come in that tied to them. I know at our last meeting we touched on the PASSes in the context of some of the legislation that was passed, but we wanted to do this discussion to kind of give an overall overview and to lead into some of the suggestions that were submitted in advance. I'll go over the suggestions that were submitted in advance. They're brief, But then I'll ask members who submitted them to expound upon them, and we can have a discussion. Or if you have additional suggestions as a result of the conversation, or something that you were thinking about but didn't send in, we can talk about that too. And with that, I will introduce our panel. We have three folks who are going to be speaking to us on the passes, including the Director of the Office of Substance Abuse and Mental Health, Paula Snone, the Deputy Director of that office, Tabitha McNulty, and the Director of the Division of Developmental Disability Services, Jennifer Brzee. So, welcome.
Good morning, everyone. I'm Paula Stone.
Jennifer Brzee.
Okay, so we'll go over this really quickly and get to your questions. Oh, I can see that one. Okay. All right, so the PASS is a program. It's a managed care program, and so what we did as a state was we decided to put a couple of populations of people into our PASS. And so Jennifer and I are here in those roles. So Jennifer is over the individuals with intellectual and developmental disabilities. And so those individuals go into our PASS program, as well as individuals with significant behavioral health issues. Not everyone with a behavioral health issue goes into the PASS, only those that need higher levels of services. So if you just need counseling services and you're a Medicaid beneficiary, you don't have to go into the PASS just to get counseling services or crisis services. So I think I covered who's eligible. You want to talk a little bit about waiver and wait list?
So in the past, it's not all individuals with intellectual and developmental disabilities. It's those that qualify for our CES waiver. So that means you have an intellectual developmental disability, but also there's a pretty significant functional impairment, which could mean if you didn't receive these home and community-based services, you might need to be in an institutional setting. And so everyone who qualifies for the CES waiver gets that independent assessment. And so once they take the independent assessment and you score, it's tiered out to 4 different tiers, about a tier 2 or tier 3, then you're automatically enrolled in the PASS. And then on Paula's side, they undergo the independent assessment as well. But again, it's only those individuals with more significant needs.
That's right, yeah, and age 4 and up. So we think children under the age of 4 and under, there are different services that they need if they have a mental health condition. And so, and all of those individuals get some level of, well, they get care coordination. And so the PASSs are responsible for paying for all of the services and for care coordination. So our goal in all of that is to make sure that they get the specialized care that they need, and that the PASSs would help providers develop that to reduce the excess cost of care, to allow some flexibility in the array of services, and to increase the number of service providers available in the community for the population covered.
And I think another really important point for care coordination is the development of the person-centered service plan. And so that's unique to the PASS population, where the care coordinator really works with the family, the member, their providers, to really get a detailed plan of care for this member to help give them the best supports and services they need to stay in the setting they want to stay in.
And I would just also, let's see if there's anything, and PASS members with complex needs. So we know that even within the PASS program, there are some individuals who have more complex needs because they either have a dual diagnosis of IDD and behavioral health, because they're involved in multiple systems, generally the justice system. So a lot of individuals on the side of the house with behavioral health issues also are involved in the justice system. And then we have children in child welfare custody that are part of this program that have a behavioral health condition or an intellectual or developmental disability. And so they have that extra piece of complexity to helping them. But I think, one of the things I wanted to say, kind of back to that, is about the services and really hoping that the PASS program would help create and extend services. And so we've seen that to some extent. I will say that, the PASS program we started back in 2018. We went live with care coordination only for a year, and then 2019 was the year that the PASS program started. And we all know what happened in 2020. So we had about a year under our belts with managed care or with a PASS program before we had the issue with the public health emergency. And so that really changed the way services were delivered in a major way. And so we really struggled during those 3 years to even just get the basic services together. So I feel like as we came out of the public health emergency, 3 years later, really making sure that we were focused on people keeping their Medicaid eligibility because they had not renewed during those years, and really seeing how many people came out of the PASS program because we kept everyone in who had come into that PASS program, whether they received that independent reassessment, which is giving annually for the behavioral health population and every 3 years for the IDD population. I think that, it's taken us almost until probably 2024 before we just kind of came back to a steady state with the PASS. And it looks like we are in a steady state with about 46,000 members. And so, we are now refocused, and we've come to this group quite often, I think, about all of our different programs that we're doing. We've talked to you guys about our pilot projects, some of the funding we're giving for construction. I'm really hoping to expand those services because I think there's still not enough home and community-based services available, particularly those with the very highest need. So just making sure we kind of keep that in mind as we're talking about the PASS. So the PASS is required to cover all of the services that is covered in traditional Medicaid. So those are their requirements. So we've got all of those hospital services and physician services and rural health clinics, mental health services, midwife services, all of those services.
Pharmacy.
Pharmacy, yeah. And then these are the home and community-based services, or most of the home and community-based services that we developed for the behavioral health in the population and those with intellectual developmental disabilities. And I think that, some of the things that we have, we continue to struggle with some of these, particularly in rural areas, and particularly for those that are very difficult clients to serve. Here are excluded services, which means that Medicaid pays for those separately. That's dental benefits, non-emergency transportation, school-based services that are provided by school employees, and skilled nursing facilities. So when someone gets to the point where they need a skilled nursing facility, then they make a decision whether they're going to be able to maintain in the home community and get those services for intellectual and developmental disabilities and behavioral health, or whether they're going to go to a skilled nursing facility. So we move them out of that PASS program.
And also individuals and AR choices and independent choices, some of our aging adult waivers, those folks go into those waivers and will leave the PASS.
And then Human Development Center, did you want to mention that?
Yeah, individuals that have full admission to one of our HDCs, which is one of our human developmental centers, also are removed from the PASS if they go into a full admission. But we do continue to provide respite. So some of the PASS members who just need a brief stay, a brief break away, they can stay in one of our HDCs for what we call respite and then return back to their home and community-based placement.
So are there any questions just about the structure of the PASS before we get into your questions?
When you created the passes, was that the population that you were thinking about putting into there? Because like when I think of complex care, I think of my son, epilepsy, asthma, autism, IDD, blindness and low vision. But it just kind of seems my experience that it's been very difficult to find a team that can really handle that. And I will give a big shout out to Summit. They have an enhanced care coordination team with nurses. I was telling Jennifer about it earlier. They're writing integrated PCSPs, and they're teaching me about his epilepsy. I mean, that's really what we need as parents. But when you created the PASS model for care coordination, was that thought about?
Yeah, I think when we created it, I mean, when you develop any program, you develop it for, you try to look at the broader population, the big population. And Amy, as well as everyone else, that population, your son has got a lot of medical needs, where we've got a lot of, the biggest population of children in the PASS are on the behavioral health side. And generally, kids with behavioral health problems are pretty healthy, right? You know, they don't have a lot of other physical health needs that go along with that diagnosis. So I think you're exactly right. We developed care coordination to serve the entire population, being adults and children. So we didn't narrow it down to specialties. But I think as soon as we got the PASS program rolling, one of the things we very quickly identified was the need for extra training. So we did that high-level care coordination training for the entire population. But then I think each PASS kind of started narrowing down to see what we need to do for our members that have more complexity. Like you said, getting a nurse on, like having a multidisciplinary team, because our care coordinators are bachelor's level people, and they have some experience in the field, but we don't have, our care coordinators are not nurses. Our care coordinators that we contract with the PASSes to provide don't have that level of knowledge. And so one of the things we really wanted to do was to pull out and identify those with complex needs. Now, I will say our definition of complexity has been, we started out with dual diagnosis. That's really what we started out with. And then we went to a more expanded view of that, which really is that multi-system involvement, like involvement with that care coordinators can do. So judicial systems and going to court and making sure that people need. So I don't know if you want to talk a little bit about the high complexity medical needs as well?
Yeah, I wanted to actually say that this is an opportunity where the PASSes and having managed care, it's really been a positive, I think, for Arkansas. Coming from, and just disclosure, I helped start 2 of the 4 existing PASSes. And so working with these managed care entities, I can tell you that their viewpoint and where those folks came from was from a strong medical background. And so all of the things that these companies had in place already were heavy on the medical side. And so it was a learning curve to bring in the care coordination and talk about these home and community-based services. And so I think that's been a great marriage of care coordination and bringing in these managed care companies who already had very strong focus on the medical, and then bringing in care coordinators who had, as you know, Amy, we recruited a lot of people from existing providers who already had a strong IDD and behavioral health background. And so, anyways, just a shout out. I think that that's been a strong point for having the managed care entities.
With the utilization management is that when it comes to that, it's harder to review a child that has all of it, IDD, behavioral, and high medical. So most of the time, the parents, and I think I'm not just speaking for myself because I see this on the Medicaid Saves Lives, we're getting a lot of denials because they're not equipped to look at the complexity of it. And then you're fighting for the services because the traditional guidelines are built on one or the other and not that complexity. So that's kind of if we could take a look at that, maybe in the MAC committee, about just those guidelines utilization-wise and the number of denials that happen with kids or adults in that complex situation. And again, a big shout out to Summit that they are working with that and they're trying to take a look at that. But it's been very frustrating in terms of parenting and trying to get services through for a complex child or individual.
I think it's a great idea. And I can tell you, it's been a learning curve for some of these managed care companies because what we did in Arkansas with the PASS is very unique to the entire United States in putting these 2 populations into managed care first. And so it has been a learning curve, and I think all the PASSes have continued to grow in that area of understanding the complex nature of having IDD, behavioral health, and in the medical. So.
Yeah, and I was thinking about that from the perspective of, we required a pretty bright line between care coordination and utilization management, you know that. And so because we knew that we had care coordinators out there that really were not, that the providers need to request the services and utilization management with the provider and the parent. So I think it's always been a little confusing about their role. And I think you're pointing out, one of the things that I don't know that we've completely worked through, as Jennifer was saying, I think we've tried it with this complex care, but I think we lean more towards that, multi-system involvement in legal instead of that medical piece. And I think that's what you're talking about, is how do we do that? How do we involve a multidisciplinary team? How do we involve the care coordinator? But how do we not, and then also, as services are being requested by the parent or by the provider, then how do you, call out specific cases where there's some nuances, right, in what the needs are, because there's some complexity based on this other diagnosis. Like, it's not a one-to-one, right? It's not like, oh, I need this service to treat this diagnosis, but that impacts this service to treat this diagnosis. So I don't know if, the requests are coming in like as a bundle, or they're coming in from all those different. I wonder if there's something we can do there. Does that make sense at all?
And I worked at a PASS and as a leader, and I was trying to build an integrated model where the PCSP, which is the plan for our family members, rolls into what they need for utilization. Because as a utilization person, if you pick it up, it's just kind of cold turkey. If you don't know the care coordinator. But let's be honest, the care coordinator is the biggest advocate, other than the parent and the provider, for the member. They know them inside and out. So if Summit has built, my care coordinator wrote a wonderful, I wish he'd worked for me when I worked at one of the passes, a wonderful integrated utilization management and care coordination plan that literally the utilization manager picked up. The provider was all working on it. I've just had a good experience with them, but it was an integrated plan where the person picked it up and they were able to say, hey, this is why this person needs this, and this is the nuances. That's just been my experience.
And I think
But-
the passes have gotten a lot better
Thank you.
at having that collaboration between care coordination and and I think it's a great topic to keep, especially for the next committee.
And how much of the knowledge, or how much of that was due to your depth of knowledge, Amy, and being able to push them, right?
Fighting for some specialized DME, but my son, because the guidelines say, well, he's ambulatory. Well, yeah, but when he runs, he's blind and he just falls over, and he elopes with autism. So, yeah, we know as family members and everybody in here that you have got to keep fighting and advocating for your child. We fight battles every day, but I will just say that, Summit really gets it, and putting that nurse on there made a huge difference for me. I didn't even know my son was having seizures. I didn't know what that looked like. And I would just encourage us to take a look at that from an integrated standpoint, which is what I was trying to do when I worked at one of the passes, because it really has made a world of difference. Are we still fighting to get the stroller? Yeah, but at least it's a team, and everybody's fighting together, and it's an integrated PCSP where it all flows in together, and everybody that picks it up knows what's going on. Thank
Great.
you.
Yeah.
I'm going to just hush now. Turn it over to everybody.
So I think, here are the questions that we put up there.
One more question.
Oh, okay, sure.
Hey, Gavin, I've also got one from online as well.
I actually just want to make a comment because I have 3 children that's on the pass. And first of all, thank you to you all for putting this in place, because before the pass, I was dealing with a facility that was had high turnover rate, was very inconsistent, and it's already challenging as a mother. Like she said, trying to meet the needs of your children, and then every child is different, so they may not need the same plan. And so it's just, and then dealing with a facility that's inconsistent, high turnover rate. Every time there's someone else, they have to build a new relationship, and then you don't know if they're gonna be there the next week or next month. It was very, very stressful. But after the pass, it's now I have a village. There's a team of people advocating on behalf of my children, and to me, it helped cater to their individual needs. They're not all tiered the same, so therefore the services that they receive are not all the same. But it has been a great benefit for me. We were with my coordinator, she was able to help me get them the services they need from a more stable facility. And I can say honestly, they've had the same therapist, the same case manager for the last 2 years. That's been very
That's great.
consistent. And even the coordinator, she has been amazing. She goes above and beyond, making sure that they are getting what they need and also additional help as well, additional assistance. And so it has taken a load off of me because now we're a team. Oh, we have a team. And it's not just me thinking about, okay, when is the next assessment due? They're letting me know, hey, go ahead and schedule that. And not just like a week before, but months out, get ahead of it, so to help us continue the services. And as the kids progress, guess what? If they're no longer a tier 3 and they move to a tier 2, we're able to catch that and put in a better plan to help serve their current situation based off who they were years ago. So kudos to
great.
you all for putting this in place because it's working for my household.
Thank you. That's great. I love it.
That was really great. Yeah, I think that was our goal in all of this, is that we knew we didn't have that care coordination level that was not embedded with the providers, right? That we didn't have that backed up, could see the big picture. And so it doesn't, I think it hasn't worked that way.
that's great.
Yeah, from the
love it.
beginning, it was quite a struggle. I'm so glad it's working for you.
All right, and before we get to these, we do have one question online, so we're going to try out the new technology.
All right.
Would you please
Well,
ask
no,
Tyler
he's not wanting to talk out loud. He's written the question in the chat.
Oh, okay.
So
Well,
we don't get to play full
we'll
full
save our
tech wizards
debut
today.
for, later. But Keith, why don't you read the question?
Yes. So this is from Tyler, Tyler Daly. He would like y'all to talk briefly about how different passes cover different services. And the example that he uses is that at one, they covered urgent care clinic visits, and the other required a PCP referral first, just as an example of what he's talking about. But how do they generally handle different services across different passes?
That may get to the second bullet point in here. I don't know, maybe you want to start with that one, then we'll go back to the first.
Yeah, definitely the best place to start is looking at the PASS's individual provider directories, which they are required to be online and available, because it is true, like not all providers are in each PASS's network. Although I can tell you from a PASS side, we tried to get every Medicaid provider in the state in everybody's network. It's just a reality that not all providers are in all PASS's networks. So that directory is the best place to start. There is a few things like urgent care that are a little bit different. I know some of the PASS's, using urgent care as an example, follow what Medicaid's been doing, and then some of them have tried to make it easier to go to urgent care by lifting that PCP referral restriction. So again, the best person to talk to about some of those differences is your care coordinator. The care coordinator can help you navigate what some of those unique things might be. And then online on their directories, and then if they have any big difference, there's usually a posted policy that should outline what that is on their website as well. But care coordinators are a great place to start.
Yeah, and they're required to cover all of the same services. So any service that Medicaid covers, they are required to cover and provide. So if there is a service that is not being provided, we need to know about that. And so we'll have the numbers at the end. But if it's something like there's a PCP referral required for one pass and not for others, I'm with Jennifer. I think website and talking to care coordinator is the best way to do that. And so, and then just also to note, you may want to call us and talk about that as well, because there are some things like during the legislative session, there was a law that got passed of you cannot require any sort of prior authorization for a crisis service or an emergency service. So we could talk to someone about, what falls within that crisis service category, and making sure that that we are working with our passes to follow all the laws. This one's a new one, and so there may have been some where is this really a crisis service? Is this something that we need to do to work through? And also be able to give you some timelines on that of when it has to be implemented.
I think, Amy, did you have a question?
I think my biggest frustration is the wait list. I know we don't have time to talk about that, but the alignment of the passes, and it's very frustrating for all the members and parents that different passes cover different things, and then we're jumping from pass to pass thinking it's going to be better, and then you may actually be jumping out of a frying pan into a frying pot. I mean, it would be wonderful if we could create some educational materials and get some alignment there, because as a parent, like you were talking about, we're just struggling, and we're having good experience with care coordinators, but there's also people that don't hear from their care coordinators. There's people that don't know what the wait list covers. I'm learning way more just navigating the systems as a parent of special needs children. I have 4 than I did, honestly, sadly, working at a pass. And this has been good for me. But what I see is the wait list, is the waiver wait list, is that I have 2 children on there, and I mean, and you want to listen to the parents that have the most experience, but then if you jump into another pass it's just so different from pass to pass. And
Yeah.
personal care is one of them. We won't bring that up today. We know that's a lifelong discussion. But for us who's trying to navigate that, there's nothing published. They won't put anything out there. There's no waiver or wait list package. And then you don't know what to do. You don't even know what you're entitled to, much less, or what your child is entitled to get or what they
Right.
can receive. It's just kind of confusing and a little bit of a mess.
Agree, and I think to Paula's point about upcoming legislation, there was also, I think, a rule about some scorecards and some better information that the passes will have to start publishing. Better, which I think the intention is fully to, like your point, Amy, better inform parents on what passes are doing, satisfaction, wait times, those types of things. So looking forward to what that may look like in the future too.
All right, you want to go over the other bullets?
Yeah, so the first one is survey past members annually, possibly twice a year, to gauge satisfaction levels and areas of possible improvement. And so there is a quality survey that's put into place that we do standardly. Some passes do more than an annual quality survey, but that annual quality survey is required. And then back to what Jennifer said, is we had not been publishing the results of those surveys in any way or distributing those. And so, Tabitha, I don't know if that's part of that legislation, or if you know off the top of your head if quality surveys are part of that, but we can go back and see if that's something that we would need to publish. And we give that to our external quality review organization, and so there's an annual report that would be available to everyone. It's pretty thick, so we might want to pull out highlights of that.
Yeah, hard to navigate, but those are out there now, the EQRO results from the satisfaction surveys. And I know, coming from a pass, some of the passes do it quarterly. And so again, if you'd like to be part of that, your care coordinator is the best place to start.
And then the last question was about denial justifications. So when there's a service denied following an authorization, you should be getting letters from the pass that explains the basis for that denial and how to appeal. So again, if you're not getting those letters, you need to let your pass know, and you can also let us know. So this is about our pass support contacts. We have a beneficiary support line at DHS. We have an ombudsman office. Those are really important phone calls to make. I mean, we do want you to address that with your pass first, but if you don't get the answer that you need, we want you to call us. We follow through with all of those concerns and complaints. We also use it to look at overall pass performance, any complaints that we get, and resolution of those complaints. And so it is really important. Our ombudsman has been with us since the very beginning of PASS, since 2018. She's got years of experience, really understands it.
She's great.
I see we've got an online question.
Yes, a follow-up question, I think, on what was going on from Tyler. 2 questions, really. How quickly does the denial letter come in, or have to come in? And could there be a way to get those emailed, possibly to make them get in our hands faster?
So I know that passes have varying levels of member portal accesses, and so some of those portals you have to opt in usually to get that email communication or that letter sent to your portal access. So you should definitely, again, check with your care coordinator The member handbook for the passes is also a good resources on what their member portal access you can get. But I believe the denial letters have a very quick required turnaround time for those to go out. The lines that are displayed, you can ask for member services on any one of those, and they should have immediate access to any denials or determinations. And so really calling sometimes is one of the quickest ways to get what the determination has been made or where that is at in the process. Had another thought, but it's gone.
Okay.
Oh, and just reiterating too, the letters, that the passes have to, like, it's contractually required that they have to describe in detail why a service has been denied. If you do not see that, that is an excellent example to share with the Ombudsman's office so that that can be addressed by us.
Are the care coordinators able to see? I know where I work, they can only see part of what's going on with the utilization stuff. But most of the time, you're going to call your care coordinator crying and, sometimes screaming, and that this service got cut off because by the time you get the letter, it's already been cut off, and a lot of times my denials sometimes are not put on the portal. I don't know what the turnaround time is for that, but are the care coordinators or will we be able to talk about the care coordinators, be able to have access to kind of know, or somebody just sending a notification to them to say, hey, this child's personal care got cut off, or they're not going to get, because normally your first point of contact is going to be your care coordinator. And if they don't know what's going on, then it's just even more frustrating.
I mean, even if they don't have access from a technological standpoint, they are the best person to escalate that internally to find out what's going on. And I can tell you, like, coming from past world, I fully expected, like, there is an expectation that your care coordinator does know what's going on, if there is communication going on. But again, if you don't see that happening, please let us know and we can dig into it.
Any other questions in the room? And I see Keith shaking his head. No more questions online. All right. Well, thank you, Director Stone, Director Brzee. We appreciate you sharing all that information. Some really good discussion there. And just as a reminder, please do be thinking about some of these ideas and what we want to potentially bring to the Medicaid Advisory Committee at the end of the meeting. So we'll have that discussion a little bit later. But thank you very much. And I believe we're a little bit ahead of schedule. We are going to work in a break, but if everybody's good, we'll go ahead and do our transportation session with Division of Medical Services Director Elizabeth Pittman, and then we'll take a quick break after that. So, all right. Welcome, Director Pittman.
All right.
And got that board back.
I don't need that.
Oh, that's right.
I don't have slides. Hello, everybody. So we're going to talk about non-emergency transportation today. I did not prepare slides, so I'm just kind of going off this quick fact sheet that I put together for everybody. It's got a few bullet points. I've also got a few other things that I'm going to talk out of today that we can provide you after the meeting if you would like. One of which is the survey. We do biannual surveys of all of our net members, or utilizers. And so we send out surveys to anyone that can use net services, and those results are published on AFMC's websites. They do those surveys for us. The last one was done and published for 2023, so we're in the process of doing 2025 now. But you can see results for 2023 on that website, and we can get those to you. I'm going to talk a little bit about those. And I'm also going to talk about this right here, which is a 2023 work group report that was published. There was an act that was passed in 2023 that required us to do a study of utilizing rideshare services in net. We conducted that work group, and this is that published paper. It's about 11 pages long. So we'll also can provide this to you if you would like it. But just so you know, I'm going to be using some of those. All right, so what is non-emergency transportation? Non-emergency transportation, what we call NET here in Arkansas, and what might also be called NEMT in other states, non-emergency medical transportation, is a required service in Medicaid. So under the federal law, we have to provide non-emergency transportation to all Medicaid to certain Medicaid beneficiaries
for all medical services. So to get you to your doctor's appointment, your physical therapy appointment, your if you have chemo or dialysis for end-stage renal disease, we provide net services to your day treatment. So like your earlier intervention day treatment or your adult developmental day treatment, your mental health services, any of those services where you have an appointment, you can get net services. Here in Arkansas, we use what's called a broker model. So some states use more of your traditional fee-for-service model where they enroll transportation brokers and pay them directly. We don't do that. We use what's called a broker model. So we contract with brokers in the 7 regions across the state, and that map is on here. You can also get a bigger version of it on our website. But that shows you what our 7 regions are and which broker covers them right there. We use 3 brokers. Verida, which used to be Southeast Trans, and they cover about 5 regions out of the state. Central Arkansas Development Council, or CADC, and then SEAT, or Southeast Area, I can't remember exactly what it stands for, transportation, I think. But it's on here, it's listed as Area Agency on Aging of Southeast Arkansas, but we call them SEAT, which is a fun little, kind of makes me think of a bus seat. So anyway, those are the 3 transportation brokers that we use here. SEAT and CADC only provide transportation in 1 region in the state, and then Verida provides it for the rest of them. They can then hire or contract with other companies to provide those net services. So not every van that you see around is owned by one of these 3 brokers. They do contract with what they call subcontractors. And then we also have some direct bill services that we can talk a little bit about if you want to, but they're not part of our non-emergency transportation program. Direct bill transportation services do include like ambulance services, and there are non-emergency ambulance rides where you can go from a nursing home to a hospital or vice versa. That's pre-planned, and we put you in an ambulance and you go from one facility to the other. That is also not covered under this program. The other direct bill transportation is what's called a development or day treatment transportation. Sorry, I'm trying to remember all my acronyms. That's what takes you daily to your EIDT or ADDT. Right now, we are moving that back under NET starting next year. But right now, that is a separate form of transportation, and they also have a direct bill where they can the provider can directly provide that service and they can bill us. That's also not part of this. So just kind of giving you what is part of this. Most Medicaid beneficiaries get net services. There's a few groups that don't. Those that are qualified under Medicare and do not get any benefits. So they only get the premium assistance under Medicare. So we're paying their Medicare Part B premium or copays. They don't get net services. People that live in a facility, so if they live in a skilled nursing facility or an ICF, they don't get transportation services. The facility would provide those for them. And then kids that receive services through our Kids B, which is our state children's health insurance plan. So it's those kids that are above a certain income level and they may have copays when they go to the doctor. They don't get the full range of Medicaid benefits, and NET is one of those benefits that they don't get. All right. What are some rules around NET? So there are a few things you have to do to get NET services. One of them is you do have to call at least 3 days before your appointment. So these transportation brokers are responsible for providing transportation services to up to 700,000, 750,000 beneficiaries, right? And those beneficiaries can all schedule an appointment. On average, we serve about 21,000 beneficiaries a year, and we provide about 550,000 rides a year. It's a lot of transportation. So we have to know kind of when we're going to need to pick you up, where we're going to need to take you, so they can schedule all of that, similar to how anybody would schedule, how you schedule your pickups and drop-offs and everything like that. So we do ask that you call 3 days in advance to schedule that NET ride. There are very few exceptions to that. One of those is you're leaving the hospital with a planned discharge. The hospital can call and do that. Otherwise, we need you to call in advance. You cannot have another ride available. So if you have a car that you can put gas in at your house, NET is not available. And when you call to schedule a NET ride, they'll actually go through a list of what they call gatekeeping questions. And there are things like, do you have a car? Can you afford to put gas in that car? Do you have a family member that can take you? Things of that nature. If you do have another ride available, then NET is not available. It is really meant to be a service provided to make sure you can get to the doctor. We do offer what's called a standing appointment for certain things. So if you do have chemo or dialysis, something you're going to go to 2-3 times a week and you know you're going to go, you don't have to call every time you're going to go to that appointment. You can work with a net broker to tell them your schedule, and they'll create what's called a standing order for you. And that just means that they'll pick you up for each one of those appointments without you having to go through that gatekeeping process every time. So there are certain things, EIDT and ADDT, where you go 5 days a week, they use that standing order process as well, so that you don't have to call every day. And in fact, I believe what they do, Jennifer told me, is they have the facility send them a Excel spreadsheet of all the kids that they need picked up, and then the transportation broker uses that to schedule those rides and get those kids picked up. So you don't really even have to call for those facilities, which is great. We do have some things available, not just a van. So the brokers can offer a variety of different ways to help you get to your appointment. They can offer you a bus pass if you live in an area with a bus. They can offer you the actual van ride, which is what we all think of. They can give you mileage reimbursement if you can get gas in your car, but maybe it's going to mean that you can't buy groceries that week. They could get you mileage reimbursement. If you can't get the gas in the car in the first place, they can offer you a gas card so that you can go put gas in your car. And they can also offer cab rides or ride shares, so Lyft and Uber. And that, in fact, is what Representative Pilkington wanted us to look at, is how to expand use of Lyft and Uber in NET when he created that work group. And I will say one thing about that. One of the things, we are a 41% rural state. On average, the nation is 14% rural. So we're significantly more rural than the rest of the nation. We have a lot more areas where there are not a lot of people. And there is not a lot of Lyft and Uber if there are not a lot of people, as you may know. I know during COVID, it was hard to get a Lyft ride here. So I can't imagine that you could ever get one in a small town in Arkansas, right? So we kind of had to re-examine how useful Lyft and Uber would be across the state of Arkansas in that work group, and really determined that the use of Lyft and Uber would be better to help with brokers using those services where they're available, Fayetteville, Little Rock, and then where they're not available, that's where they would put their drivers and their more traditional forms of transportation. So it would allow them to sort of flex how they use their transportation across the state versus it would really provide a statewide solution. All right. We do have some oversight of our net vendors. I mentioned the surveys. We also use AFMC as our net vendor manager. And so what they do for us there is they actually inspect our net vehicles. So they go out and they make sure those net vehicles are meeting safety standards. We have a whole list of things that the net vehicles have to do. They have to be clean, they have to be safe and operable condition. They have to have cameras in them so we can see what's going on. They have to have those child safety alarms that go off at the back of the bus when you stop it, and then the driver has to go walk the bus and turn it off. That's to make sure kids don't get left on vans, which we all know has happened across the nation. It's a sad thing. We don't want to see it happen here. So we make them put those alarms in the vans. They have to have handicap lifts and seat belts and all of those types of things to make sure that the wheelchair lifts or the, you know what I'm talking about. All of those things to make sure that the transportation is safe for the people that are using it. If you have any problems with any of that, you can call the line that is on this website here, on this sheet here that we can give you a link to, so you don't have to use a magnifying glass to read it. And you can make complaints about the state of the vehicle, the safety of the driver. They do look at the drivers. They check their background. They make sure that they are licensed and have the appropriate license, that they've passed background checks, including a criminal background check, a child welfare, and an adult protective services background check. So we really want the driver and the attendant to be very safe. So we also want to know if they've sped, or they didn't follow traffic laws, or they didn't make sure that your kid was buckled up when they took off, right? We want to know those things. And when we hear those things, we actually send AFMC out to do an investigation. They do investigations for us, thankfully, not too often. We don't get them all the time, but we do get them. And when we do get complaints that rise to the level of an investigation, a serious incident, an accident, something like that, AFMC does go out for us and do an investigation of that. And we usually take action based on what we find. It could result in the termination of a driver. A lot of times it results in having that broker go back out and do more training across their staff. We find that a lot, that the drivers just weren't following the protocol, and we need to make sure that they reinforce what those protocols are. Making sure that someone's buckled up before they take off would be an example of that, right? We want to make sure that drivers know to do that. So if we start seeing a lot of incidences or complaints where that's not happening, we'll have that broker go back and redo that training. We also use those surveys that they do. They send out surveys to the beneficiaries and ask questions regarding satisfaction with net transportation, including driver safety. That is actually on the website, like I said, and I will tell you, we did see a little bit of a decrease in 2023 that we are looking at, but I would say that right now we still have overall favorable satisfaction. It's 73% total satisfaction with net, which is, I'd love to see that higher. I'd love to see that closer to 90 or something like that. But it's still more than half of people are overall satisfied. The ease of getting a ride was at 92%. People are 92% satisfied with how easy it is to get a ride. Timeliness and reliability, 87%. Again, that's something we want to work on. We do get a lot of complaints that net riders or net vans are late to pick people up, thus making them late for their appointments. We want to make sure that gets better, so we're hoping to see that increase. Courtesy of the net employees, 92%. Safety, 92%. The overall rating of the net broker, the average rating was 8.1. Average rating of the net ride was 8.2 out of 10. And the average rating of net services was 8.2. So again, all of these are considered favorable survey results. Nothing was considered mediocre or unfavorable. So that is exciting. It is on the lower end of favorable, though, and so we want to see those go up, right? We want to continue to see our net services increase. Like I said, the common complaints we see are no pickup at residence, no pickup at the appointment, and the provider or the driver was not available. So those are the things that we're really trying to work on with the drivers, and that's why we had this work group to look at how can we expand the access to transportation. What we hear from the brokers is a lot of these, and I think your questions reflect this, a lot of these issues are caused by the fact they have a hard time finding drivers, particularly in rural areas. They just can't get enough drivers. So that's what the work group was really designed to look at, is how do we increase that driver capacity by using alternative means of transportation. And what that work group did say, I just wanted to give you those recommendations because I thought they were pretty good. Use more TNCs, which is what we called rideshare, and I can't remember what TNC stands for, but it's Lyft and Uber. Use them in Craighead and Washington counties. Right now, Verida is our only broker that uses rideshare, and they don't use it a lot in those areas. So using it more in the Northwest Arkansas and Jonesboro area. Aligning the requirements for the use of TNCs with other net program requirements, making sure the safety requirements are the same. That's very hard to do because we don't directly contract with Lyft and Uber. We directly contract with the broker, who then in turn pays Lyft and Uber for those rides. So it's hard to do that. So looking at ways to make sure that we can enforce those safety standards on Lyft and Uber is difficult. Change program policy that scheduled TNC trips do not require approval by DMS. Right now, to use a Lyft or an Uber, a broker has to call my staff, get permission to do that, and then go back and schedule that ride. That's a big administrative burden. It kind of puts a barrier on use of that. We're changing that in our next contracts with NET. We're putting out a new bid for next year so that we can start a new contract. We'll maybe getting new brokers. We don't know yet. That all depends on who bids. But one of the things we are doing is saying you don't have to get a pre-approval from us to use those things. And you don't have to not have a net van available. That's another requirement right now, is if a net van is available, you can't send a Lyft or Uber instead, which doesn't really allow them to flex how they use those. So instead, we're going to allow them to decide where Lyft and Uber is more appropriate and where net vans are more appropriate, instead of us making that decision for them. Consider whether rural coverage by current providers could be improved by paying for deadhead mileage. That's a mile without a driver, without a passenger. Right now, we pay for what's called a loaded mile. So you get it on certain things. And in fact, I don't even know what this means, because let me explain how we pay for net. We pay for net on what's called a PMPM, or per member per month basis. So for every single one of the members that you get assigned in your area, all 750,000 of them, we pay net. And they only provide rides to 20,000 people, but they're providing over 500,000 rides, right? So they get a PM for being available to every single one of those people every day of the week, Monday through Friday from 8 to 4:30 for rides. That's what they're getting paid for. And we do that for every single one of the members that we pay for net services for, all 750,000. At the end of the year, we look to say, did you spend a certain percentage of the money we gave you on rides? We look at 95%. 95% of the money we give you has to be spent to provide services, to pay drivers, to keep up vans, to do all of those things. If you didn't do that, then we're going to take back some of that money. And that's how we pay net brokers. So they get paid based on how many members are enrolled with them, and then we look at their cost overall to determine what that PM is. So I don't really know what that one means, so we're going to ignore that one. Allow brokers to deploy public transit apps that facilitate payment for passes. I think this was one of the things you asked for vouchers for people to be able to use transportation, and that is something we are looking at. We can't just pay directly with cash cards or things like that because we have to make sure the money is going to transportation. But there are some other things we could do, like allowing for transportation brokers to provide bus vouchers or bus passes or vouchers for Lyft or Net, or things of that nature. So we're looking at all of those things. And then they looked at more wheelchair accommodation vehicles, and that's basically it. So you can check out that report as well. All right, and I wanted to make sure we addressed your questions. I think I've addressed the debit cards and vouchers and the transportation studies that we've done. I would say we do get beneficiary input through the survey, so I would recommend taking a look at that survey. If you think there are things we're not getting from there, we can add questions to our survey to capture that information, or do other types of focus groups or work groups to gather that information. So I would be interested to hear what your feedback is on what we're not getting from that survey. You talked about offering rewards or bonuses to workers. We'd really have to look at how we arrange those contracts. Right now, we contract directly with the broker. We don't look at how they then pay their drivers necessarily. So we'd have to look at what we actually put in the language of those contracts. But again, having some ideas around that. Somebody suggested allowing at least 40 to 60 hours of overtime to be reimbursed for certain care plans. I'm not sure what that means. So if anybody that made that suggestion wants to give me more.
Personally, a total care individual, and it's really hard to find people to cover for my level of care need. For instance, I don't even have a substitute available for today, so I had to have a family member drop me off because I told them it was imperative that I show up here, so they respect that because they know that I'm an advocate for the entire state. But realistically, my family is starting to age out. My father died about 5 years ago. My stepfather is going through medical transitions because he has terminal illness, and I'm still able to be independent, but I'm starting to have to depend on staff like extra family members. But if they're not getting paid at least a little bit more than minimum wage, they're not sustaining the jobs for very long. So I thought that maybe proposing that idea would help alleviate some of that stress.
Okay. All right. Thank you. That really helps us understand. I don't know that transportation is going to address all of that. I think it could address part of that. But I definitely hear what you're saying, and I think that's something that a lot of the people that are on this side of the room for total care plans could look at. Transportation that we provide on the net side has to be used for medical services. There's very limited things we can do outside of that. But I think there's some things you can do in the home and community-based services area. I think Jennifer's nodding there, that we could take a look at there around how to provide sort of more comprehensive total care for you.
We got 2 questions over here. Let me start with.
Hi. In the past, whenever I've asked for a ride, they have always asked me if I have another means of transportation, but I've never really known how I can get a gas card or reimbursement if I have my own vehicle. Is there some way that us as the consumers can know, like get some information and educational material or something? Like maybe
Sure.
on these flyers to know how to go about that, because the brokers, whenever we call, they don't offer us that information. They don't let us know off,
Right. And right now, that's because of what I was talking about earlier. Right now, we have a lot of limits on when those can be used. Typically, we require the net van be the first means of transportation used, and then the other things are offered if they cannot schedule a net ride or if there's not a driver available in that area. So we're trying to look at changing that to allow them more flexibility. Also, different brokers offer different things, so that might also be what's going on. I know they use more gas cards up in the northwest part of the state than they do in other areas. And they use more Lyft and Uber rides here in central Arkansas than they do in other areas. So it may depend on where you're located as well on what's being offered to you.
because in the past, like I'm the only caregiver for my child, and she has a disability. She has autism. So whenever I've told them I need transportation for me and I'm taking my daughter with me because I'll be taking care of her, they have denied
Yes.
transportation.
That is an issue, and we are looking at it.
And not only that, but because my daughter has special accommodations, we have a handicap tag on my vehicle because she elopes, so she cannot be left alone to enter or to exit the vehicle. So that requires me to take my own vehicle because it's just more accessible for her, which would require us getting like a gas card or reimbursement.
So you can ask the broker you're using. Right now, like I said, we do have some limitations, so that's probably playing into this. We are trying to make that more flexible in our upcoming arrangements, contract arrangements, so hopefully that will make that a little bit easier for you. When you call, you can ask if that's available. They don't have to make it available right now. So, we're working on that. I would say to the other piece about not being able to take, so that's an issue that we're very well aware of. It's come up a lot in our discussions around maternal health services, particularly getting women to postpartum visits because they have a baby. Right now, the federal requirement is that it's a service. Net transportation is a service, just like any other service we provide, and we have to provide it to the beneficiary, right? So if you're the one with the medical appointment, you're the beneficiary in that case receiving that, not your daughter. And so the net broker right now can't take your daughter on that ride with you. We are looking at ways to change that, if there is any flexibility to change that. But again, that's that federal rule of we have to pay for that service that's coming into play there. And so we're trying to figure out if there's any flexibility around that. But we know that is a known issue for women with children that need to be able to take those children to their doctor's appointments with them.
That would definitely place a burden on us single moms to not be able to take our children, because then that would leave us with the cost of childcare.
Yes,
That
we know.
I believe that offering an alternative such as gas reimbursement or a gas card would cover that, well, I can't ask for this service even though it's available to me, the beneficiary. I'd rather use my budget for something else to cover this cost, especially when it's like, sometimes I've had to bring my daughter out here to Little Rock to get specialty appointments. I have to travel 3.5 hours from Northwest Arkansas to here, and that's about a $50, gas cost that, it's coming out of my pocket.
Thank you. Amy?
I just have as a single mom of 4, and I have 3 that are driving age, but they can't drive. One has a TBI, and they may never be able to
Right.
drive. So I can totally relate, to you, Angelica. But one of my questions is because I do want my children working or in work programs, and my son is in Project Search. They told me in the past that Medicaid covered that transportation and would help get them there. And that being said, I'll go about 12 steps ahead to I know that Medicaid's looking at work requirements for beneficiaries. Is there a plan to have transportation for work training programs? And does it cover the Project Search now? And how would I go about that? And is SCAT the same thing? Is that what we're talking about? Because providers tell me to go to SCAT, and I'm like, is that the same thing?
I think
or?
SCAT is the same thing, but
Okay.
I haven't heard that
Just-
term in a really
I know
long
that was a
time.
dumb question, but
No, it's not a dumb question. People still call it, yes, old names. Okay, that was a lot of questions. I'm gonna make sure I answer all of them. No, you're good. They're good questions. I'm just gonna make sure I answer all of them. So let me start with, we have looked at whether or not we can provide some transportation services to non-medical appointments for Life 360 homes. So when we started those programs, part of what we're doing is doing community referrals to work programs, to housing programs, to food banks and things of that nature if somebody needs nutrition or food assistance. CMS has allowed us to provide very, very limited non-medical transportation. They really have not allowed that. And it's very limited, and it's not to jobs right now for that population. So so if it's a Medicaid service, Jennifer may have to help me here. If it's a workforce, do we provide transportation to like supported employment? No.
One second.
Under the CES waiver, there can be transportation reimbursed by the passes under supported living. And so I do know that there's probably some instances if you're under the waiver, the CES waiver, that you're getting some extra help with if you're in a supported employment program. And then adult day treatment programs also have transportation.
For their sheltered workshops?
Yes. Yeah. You would have to check with your pass on that specific.
And non-emergency transportation right now is not covered by the passes. It's covered by a fee-for-service. So, and we don't right now provide that ability to provide very limited non-medical is only for the expansion population in that 1115 waiver, and it's only for non-work related supports. So it's very, very limited that CMS has allowed us to do. I even asked because maternal Life 360 can be provided to more women, not in that 1115 population. They said no. So it's been very, very limited approval right now. I think CMS is a little afraid to branch into that space.
upcoming work requirement, they're going to lift any of that?
I have no idea.
Okay.
Yeah, I don't know. I've tried to avoid my crystal ball gazing for what they're going to do around that. But you may reach out to ARS to see what they have available.
All right, any other questions in the room for Director Pittman? Seeing none, and I see Keith shaking his head. We have nothing online either. So thank you, Director Pittman. That was a great presentation. We are running a little bit ahead of schedule, and if it's all right with the council, we still have several members of the DHS leadership team here. Our next item is a 15-minute just open discussion. Just to, because I know some folks may have to leave, how about we do that and see what discussion we have there, and then we'll take a break right after. Does that work for everybody? All right. Well, with that, we'll open the floor here and also online in the back. So any questions you have for leadership here, we'd be happy to take.
I'd like to know what the status is of the TBI waiver program and if that's gonna come into effect soon.
It's definitely on our radar as it is legislatively required at this point, but we are still working on forming work groups and a project plan for what that'll look like. So we're It's on the radar, working on it. Hopefully 2026.
I have a follow-up question to that. Being a TBI survivor myself, having moderate symptoms like a mild TBI, a lot of the time we fall through the cracks, especially because I acquired it after the age of 26, so I don't qualify for any other assistance. And at one point, I remember when I had to leave the workforce, like when my symptoms, when I was recovering physically, for like a year or two, maybe 3 years, I went without any health insurance coverage because I didn't know that I could qualify being medically needy or medically fragile. So I would like to know also if if it can include also folks with a mild TBI, not only a severe TBI, because a lot of us have not only physical conditions that prevent us from working, but we have basically the same, conditions that impact us a lot. And also, I would like to know if the state TBI program can be have more oversight or like be implemented and like maybe having I lost my train of thought.
I just want to add to that. My son is 18 and has a TBI and autism, but it's mild. It's mostly cognitive, neurorestorative, and it is very difficult to find services. And we found a support group, but he's the one in Project Search for the autism. But concerns are without the 6 hours of therapy we're doing a week, is he going to be able to maintain in a program like that? So I just wanted to reiterate, that it is difficult for people that they present as higher functioning, but really they have a lot of cognitive stuff going on.
Yeah, no, that makes perfect sense. And I think it's been a known gap to us, especially if those brain injuries occurred after the age of 22. So anyways, all to say, great feedback. Love that y'all are sharing. And I envision that we will have some stakeholder work groups, which we will definitely seek out such valuable input as we're working on that waiver that we'll have to submit to CMS for approval.
Got a question from Jennifer?
So this is kind of a totally different topic, but have they been looking at the income requirements increasing, like for the different programs? I mean, just as me, I'm a single mom too, and losing Medicaid B was a huge deal for me because of the teacher increase. We now do not qualify for any of those services, but I'm paying $1,200 a month in rent and can barely pay my bills. So is that being looked at all right now?
That is not something that I'm aware of as being looked at right now.
Gavin, we have online questions that Tyler wants to ask out loud this time.
All right, we get
So
to give it a try.
Test the new technology for the guys in the back.
All right, would you unmute Tyler?
So I have a couple questions. My first one is about when you search online for like, let's say, for example, dental providers within the Medicaid network. I could not specify what I wanted in a dental provider. So like, for example, for my son, he needed an endodontist. I could not go into detail to find that. And when I contacted someone, they said that like basically it couldn't happen, or there's not like a mass list that I could request.
Hey.
Are we back on the room? Okay, we're good.
Okay. Hi, Tyler. First, sorry that you got told that. You should be able to get assistance with finding a dental provider who is an endodontist. AFMC also helps us with that. We like AFMC here. And they have a phone number that's on their website that you can call for help with that. And if you, Gavin, will help me remember, I can help get that to him. So if he runs into that again. Second, yes, our current provider directories search features are very limited. I agree. There are some new requirements coming out from the federal government around provider directory. It's called the interoperability rule. It does a lot with what we make available to beneficiaries regarding their Medicaid benefits and their health coverage, what services they've received, and it includes an enhanced provider directory. That includes more information on what services providers offer, what capabilities they have as far as language capabilities, serving clients with special needs, if they do that or specialize in that in any way, that would also be on there. So we are working on all of that with some anticipated timeframes of 26 and 27 to have that better search feature available. So hopefully you'll start seeing some of that really soon, and that search will become a lot more user friendly. In the meantime, though, particularly with dental care, we when you went back to fee-for-service dental, began utilizing AFMC to help us with navigating that care for both the providers and the beneficiaries, and they should be able to help you with that.
That's actually who I contacted, and they said they couldn't give me like a list. So, and I'm not trying to be like a negative Nancy. I'm just trying to bring that up to you.
That's very good to hear. Let me take that back and see if we can help with that. They should have been able to help direct you to someone who could provide those services. So let me see what we can do for that. And in the meantime, let me get Gavin to send you Nell's phone number. And somebody in my staff will try to help you if you still need assistance. Okay?
All right. Any other questions in the room or online?
I just wanted to give a shout out to AFMC. I told John earlier, because I know a lot of times we come in here and we're like, oh my gosh, this is wrong, could you please fix this? But my daughter's on our home. We had a wonderful experience with the new chat bot system, even to the point where he could actually help us, Michael, verify her identity, which that was fun because that went over to Experian and it was really confusing. But in any event, he also gave us an email to send her paperwork in because we had already mailed it and faxed it, but nobody had gotten it. So I just want to give a big shout out to AFMC for that and Access Arkansas, and everybody was just really responsive and helpful and gave us an email to send everything in, and we got her. I hope we got her stuff renewed. If not, I'll be giving you a call. But I think we did get it renewed, but it was a wonderful experience. And I was telling John it would be great if care coordinators don't know about that, to help their members, because a lot of times nobody wants to talk to the care coordinator because they are an authorized representative, but not. But it would be great I was just very impressed with how thorough and how he was able to take care of everything. So thank you guys.
Thank you, Amy. Any other questions? I see Keith shaking his head. All right. We will take, how about a 10-minute break? We'll come back here at 11:15, and then we'll close out the meeting. We will need to elect who will go to the Medicaid Advisory Committee in October, and we'll need to pick whatever ideas we want to share with the MAC. So we'll take a 10-minute break and then come back. Thanks, y'all. We just have a little bit of business left in this meeting. We're going to decide on our submissions to the MAC meeting, and we're going to decide on our representative to go to the MAC meeting in October. But before we get into that, I do want to take a moment to introduce or reintroduce for many of you Deputy Secretary Janet Mann, who is also the incoming secretary, who will be next after Secretary Putnam leaves. But Janet just wanted to take a moment to welcome everybody and share a few remarks.
Okay, can I use this one because then I won't move my hands around. I like to talk with my hands. I just wanted to come by and say hello and welcome to everyone. I know this is the first meeting of the new state fiscal year, and a lot of business to be done, and I see lots of people from DHS here ready and willing to help. And I just wanted, again, to say hello and welcome and kind of hear some mini feedback from y'all. I know this is a full day of meeting between this morning and this afternoon. We'll have different groups in and out, and there will be some crossover, but I really do appreciate y'all giving of your time and your resources to be here to help us make this a better place. So I'll leave that and just see if anyone has any quick questions. And if you don't, it's fine, because I kind of put you on the spot. Okay, we're a quiet group. They're hungry. But anyway, so yes, I am the incoming secretary. I'm going to learn to delegate, which is not one of my strengths, as they over here will start giggling. And but looking forward to that as we transition and do some things as we move through a lot of new legislation, a lot of new rules, and as we still take care of 1 in 3 Arkansans in the state. So thank y'all.
Thank you, Deputy Secretary Mann. And with that, we'll move into the final part of our meeting, which, as mentioned, is to develop the submissions that will be presented at the Medicaid Advisory Committee this afternoon. They also are required to have a formal DHS response. So to do that, I'm going to turn it over to our chair, Brandy, and we'll try and whittle down some ideas to present.
Okay, so they've asked us to come up with 3 to 5 ideas to present to the MAC committee this afternoon. I'd really like us to just kind of start with 3 if we could. Some 3 that we can all agree upon that are maybe the most important. And then if we have additional ones, we can list those for discussion for the next meeting. So does anybody want to throw one out there? Angelica?
I was looking at the bylaws, and on Article 6 about compensation and reimbursement, I believe it needs to be revised for the rotating members for the reimbursement cost of childcare when we're going to be in 2 separate meetings. It doesn't really specify.
Conversation we can have with AFMC. I don't know if that will be something that we want to have be a formal.
Okay. I brought it up to Crystal, and they said to ask you.
Okay, I'll talk with them right after. So.
Okay.
Well, y'all know I always have something to say, but I really would like, not just because I came from the PASS background, but just that complex care piece we talked about. I would love to look at the PASSes. I was talking with Gavin a little bit. I'll just be very honest and transparent, being on the other side of the house. I feel like the PASS model of care coordination in some regards of what you guys originally set it up for 5 years later has kind of moved away from that a little bit. And it's almost like our PASSes are operating like traditional managed care, like I used to work in. And that's a little discerning to me, being a special needs mom of 4 children. I would love if we could just look at the care coordination model, that complex care piece, see if you have any plans in the future for Optum to do like a tier 4 that is for high medical. I would love to know what percentage of those 46,000 members are actually like my sons, because I'll be very honest, I've been very hesitant to get my oldest with the TBI and autism assessed by Optum because I'm getting denied so much for the medical piece and the complexity for my youngest son. And that's not where I want to be. I love the PASSes. I loved working for a PASS. I love my care coordinator now, but I've been through 4 care coordinators. Some people that actually left the PASS, and my care coordinator left, and I didn't even know they left, And I'm just not one parent that's experiencing that. There's a lot of pros and a lot of cons, but if we could take a look at that. The other one I think is transportation, just overall. If Medicaid's going to require a work requirement, we need to take a look at how are we going to get people to where what your goals are and what their goals are, because it would ultimately benefit the state to get more people working and independent. But if we can't get people there, like there's no way I can get my son to Project Search and get my other child to where he needs to be for a specialized school for the blind or even to First Step. I mean, we are so reliant, especially as single moms, on the transportation piece, just the gaps. So that's just kind of, that kind of determines everything if you can get to where you need to go.
Piggybacking on to the transportation, I do think, well, first of all, let's back up to, so we talked about guidelines and percentage of denials for complex cases, those involving IDD, behavioral health, medical issues. And then I just heard you say again that the PASS model you think is operating under traditional managed care rather than the care coordination model. So I feel like that would probably be a good start for our first. Is everybody in agreement with that to bring that before the MAC? Okay. And then, secondly, on transportation, something Jennifer and I were just talking about was bringing up to them about the way that we heard you explain that was why on earth are we paying for 700 and some odd thousand people to have transportation when not everybody needs it? And so proposing that there be some type of a application process or something that's added on to the application or the screening process so that you know in advance whether or not that person needs transportation. If they would utilize it.
The PMPM, it depends on the region, but in some regions it's like $2 something a month. It's very small. And like I said, we look at, so that's on average across that. So what we do, it's just like insurance. You have people that you pay a premium and you may never see the doctor, right?
Right.
But you still pay an insurance premium in case you need to go to the doctor. That's what we're doing. So we pay a premium in case somebody needs a ride, and all 750,000 people can utilize that service, every single one of them. And that's what we pay for them to have access to that service. And then at the end of the year, the net broker sends all their costs and all of the rides they provided, all of that to our actuaries, who then go, on average, it costs you this much money per however many people are in your plan to provide that service. And that's what we then turn around and pay them. Okay. So they are getting paid for each one of those people, but it's based on their costs. So I probably didn't explain that very well. But it's just like we set past PMPMs.
Right.
So you have really high utilizers and really low, and we're averaging that across.
Okay.
Does that help?
Yes.
Okay.
Yes, it does. Yes, I think we'll scratch that question. But we did talk about some other things that we talked about were the past wait list and better information needed on that. You want to?
I think in general, the waivers, we talked, I believe last year about doing, and I was asking Gavin about, y'all did a HCBS one-page education. It would be great to have that for everything out there, because as a parent, and a roadmap of, if you don't, like I think Access Arkansas, your improvements of, if you don't qualify for this, it automatically kicks you over to what you do need, right? But otherwise, you just don't even know. You know, it's so many waivers, it's so confusing. And like the TBI waiver, you know, a lot of people don't even know that came out, but to have those one-pagers that providers can give out, and we all have the same educational material, like the HCBS one-pager would be great, especially some education about what does it even mean to be on the wait list? What can you get? You know, what is your family member able to receive, you know, and how do you even go about that? And I think I've said this before, but for my children, they all have disabilities. It was through 15 hours sitting down with a DDS worker to do the packet, because I was confused, and I worked for a PASS, and I have a degree, but that doesn't mean I have a degree in this, you know, in being a special needs mom. But it was really confusing, and the packet alone is 36 pages. So I think a lot of people just give up, and then they end up homeless, or their children are taken over because they just don't. I mean, that's the worst case scenario, but if we could have some education from start to finish and a roadmap of how to navigate it.
So is that something you want?
I would like if we could do that. I think that HCBS one page has helped, but I think a lot of people.
And can we
just don't
clarify
know.
which waivers we're talking about? Let's make sure that, yeah.
Just to repeat it on here, ask if we can clarify which waivers you want to be
I
included.
think we need I think all of them.
So
Like
we
what-
have what? We have an autism waiver, the IDD waiver, and two, payer choices and living choices. So we've got 4 waivers. Yeah.
And now the TBI waiver, but you said 2026 for it, right?
Yeah, there's no information about that. But on our website, the HCBS,
Hold on
it's
one.
actually sorry guys. Yeah, it has on our website for the education campaign, it actually has a one-pager for every waiver, and information that links to all the programs right now. And so anyways, it's a great existing resource that has educational, like small digestible bullet points about what each waiver covers, how to access it, how to get into that. And so anyways, just throwing that out there that the HCBS website is not just CES waiver. It covers the whole universe of existing waivers right now.
It also has like private duty nursing, independent choices, personal care, what TEFRA is, at PACE. It has all of that on here.
I guess since none of us knew about that, then nobody else knows about it. So
We're working on how to get better information out to people.
Right.
That is the thing we need.
Right. That would be it.
I think, just a suggestion that you might think about as an option, it could be to review that website and see what you think is missing, or ask us to review it and see, something like that might help refine that further and add what.
How to disseminate that out to like Medicaid to everybody.
Yeah.
Okay, so is that something that we want to put on as number 2? Okay. How about thirdly? Anybody have a third one? Angelica?
Mine was the income increase. Yours is what? The income increase.
Oh, yeah.
Do you want to go, Sarah? Go ahead and share it with the group just to.
Well, I mean,
I know we already talked about it, but.
Yeah, I mean, my biggest thing is I do feel like that the income increase needs to be looked at, even if it's not at the state level. I mean, I know a lot of that is federal, but is there anything that we could propose to the federal about doing this? Because the cost of living, the cost of groceries, the cost of cars, the cost of gas, like it is insane. It's doubled for me. And even though my income went up like $4,000, that is not covering everything else that I'm doing, plus not getting Medicaid services anymore has tremendously hurt my house, my family. So I just think that's something that we could definitely at least propose to get talked about.
Mine was the 40 to 60 hour approval limit, maybe for care plans similar to mine, on a special basis.
All right. That would be 4. Do you want to keep it at 3, or do you want to vote on?
I can certainly do that. Angelica, what did you have?
I wanted to expand on the bylaws, section 2 purpose. On number 1, to ensure the views and needs of Medicaid providers and beneficiaries are considered in the development and implementation of Medicaid policies and programs. I would like to add some verbiage about utilization review to kind of cover the gaps in coverage. There is a lot of like waiver programs and even developmental disability services, but there is nothing to cover individuals that have acquired disabilities like neurological disabilities. So I would like to suggest that there be like a case manager to add like an extra level of care. Since there is no current TBI waiver program, to kind of help, people cover the gaps in coverages that we have been getting so far.
Okay, so you were referring to talking about the MAC bylaws?
I don't know if these suggestions aren't necessarily meant to govern how the MAC is used. I mean, those are discussions that may make sense outside of the recommendations to the MAC.
Right. That's what I was thinking.
I can add where that came from. Just gonna let you know. That is the federal regulation language of what the purpose of a MAC is, so I don't know like if you want to put that there versus take a consideration to them, just so you know.
Right, right. Yeah, I don't think, I was going to say, I don't think that needs to be part of the bylaws, but that might be something that we can take to the MAC as far as for further discussion with that. Okay.
More so along the lines of having case management. Having case management versus having.
So are you talking about case management outside of the passes? Because we have care coordination with the passes, which is what a case manager is.
Yes, and the purpose of that is to cover, there is a special, like developmental disability services, but there isn't any services that cover specifically people with not only developmental disabilities, but like TBI survivors, stroke survivors, a separate category, even like on the application, because a lot of us, like, we're left. For example, I cannot get like eye therapy and physical therapy at the same time because that all comes out of the same bucket. But if we have like a separate category for people that have not a developmental disability, but like an acquired disability, then that will help us review like what the needs are and the gaps in coverages for us better.
So, yeah, so acquired physical disability falls under aging, right? So it's, and that's the waiver. There are two waivers, living choices and AR choices. And so that is that's the different, that's why I was kind of asking about waivers and which waivers y'all wanted to focus on. And so even for people who are not elderly, right? Like a lot of times your physical disability is related to the fact that you're elderly, which is why my foot hurts right now. So, right. Yeah. So I've got issues related to my aging process, but then some people have a physical disability. And I think that was one of the things we recognize is that you don't cleanly fit into, because the IDD waiver, the CES waiver, will treat if the condition was before you were 22. There's certain diagnoses, but then we knew we were missing some diagnoses that either occur before the age of 22 or that occur after, and all we really have is that aging waiver right now for anything that you're acquire, whether that's a brain injury or you have a car wreck or whatever it is that happens to you after the age of 22. But that's that waiver, and then and that's when Elizabeth was talking about the TBI waiver that we want to, oh, that was Jennifer, sorry. Oh, I heard you answer. So that's the one that we will be putting into place, because again, we knew that there were people that were kind of falling in between the cracks of either the aging waiver or the IDD waiver. And really with the IDD waiver, traumatic brain injury is not one of the qualifying diagnoses, or right. Right. So I think right now what we've got are the IDD waiver that have qualifying diagnoses, and then some other diagnoses that if they happen before the age of 22, you might qualify for that waiver. We've got the one for aging and physical disabilities, which is the one that Jay runs, but it's in the aging division, adult and aging. That's right, adult and aging. But it is a little confusing. So probably most of the people on that waiver are, have some physical disabilities related to the aging process. So I think, and then we want to bring in that new waiver specifically for TBI, because there's a different set of needs that you would have for that maybe is not the same set of needs that you would have for like dementia. So I think but I think you could look towards, are you eligible for is somebody with a TBI eligible for the adult and aging waiver now?
So, for example, if my eye therapy isn't related to aging. Okay, so currently I need to go see the eye doctor to get eye therapy, but that's not related to aging.
Is it related to a physical disability that happened to you after the age of 22?
Yes.
So then you might be eligible for that waiver. It's for adults with adults and those that are aging that happen after the age of 22.
Okay.
Sounds like Elizabeth wants to explain.
I'm not the right person to explain all of the details. I would just say, similar to the CES waiver, any home and community-based waiver, it does require that, and I think in that waiver, and I wish Jay were here because he knows more specifically, it's needs in 2 different activities of daily living. So like toileting, dressing, mobility, feeding. That's where you have to meet that, what they call institutional level of care, and that's how we establish that. So that's, I think, one limiting factor to that physical disability waiver. But she is right. It's not just for those who are aging and having, disability related to aging. So it's not just dementia or Alzheimer's or other things like that. It is any physical disability at any adult age. I think 18 and above.
And so it sounds like so if you don't meet those for a waiver, because the waiver is that we are waiving other requirements, right? To say that because of your disability, we as a Medicaid provider can waive some of the requirements that we would have for a general Medicaid population. So if you don't meet that level of care, it sounds like that you're bumping up against some issues around maybe NCCI edits, or it sounds like it's, So I think that there may be, and I'm not sure if you're not able to get multiple appointments on the same day and you don't qualify for a waiver, I think that's.
Sounds like an NCCI. If you're having
It isn't.
with that, it is probably some sort of edit issue. You can call us and we can see if there's anything we can do. The NCCI edit, National Correct Coding Initiative. I try not to use acronyms, but that doesn't mean much to anybody. That is a federal rule, and you have to specifically ask CMS to waive it, and they don't grant waivers very often. I will say that. So if that's what's causing it, there's very little we can do, but call my office, and apparently I'm going to give a whole slew of my staff's phone numbers out today, but I can get you to my utilization review team to take a look at that for you.
It will be covered. The issue is that it won't be covered if I'm doing another therapy at the same time, because it will be pulling from the same bucket. Like, so I can't get therapy. Yeah.
And I just have a question. Like, my son's 18, TBI, autism, IDD. Again, it goes back to kind of the conversation we talked about with the medical, the IDD, and now I have this child with this brain injury. Where would he fall? Like, what waiver, is there a waiver for him? He's on the wait list for HCBS, but that's not really covering the TBI stuff. That's my first question. The second question is the TBI waiver going to be age limited?
I think those are all good points for us to take into consideration. We're just in the research phase, so we have not started that work yet. But this is great feedback for us to take back.
All right, Brenda, you want to go over kind of where we stand? We still need to, I think, finalize what.
So we've got 4 items to bring before the next committee, talking about the past model operating under traditional managed care rather than care coordination, guidelines and percentages of denials for complex cases. That would be the first one. The second one, we kind of modified that to say we need to review the website to see what information is there and how we can disseminate that information more widely to the public. 3, the income increase. And Jennifer and I will get the verbiage together for that. And then the 4th one was on transportation, allowing for overtime to be reimbursed to providers for certain care plans that provide total care for clients.
I was going to say, I don't think she's not talking about just transportation. She's talking about waiver services in general.
Yeah,
because they can't.
Home
Yeah,
and community-based
Okay.
waiver.
Yeah.
That's
Personal
what
care
it is.
services.
Personal care. Yeah.
Yes.
Across all personal care.
Overtime allowance for that.
And I hate to play the devil's advocate here, but how do you provide for an adult who has Down syndrome and a severe case of dementia at the same time? Like, those are things that I'm thinking about as I interact with people in the community every day and find people facing all these problems. First of all, they don't even know where to go to access services or to get questions answered. So you have to fight through all the red tape. And then secondly, it's confusing because they don't know where they fall into categories to be able to qualify. So what do you tell those people? Like,
That's such a good point, and it is very, very difficult. You know, a lot of what we do is, particularly for our past members, and when we started the pass, you know, we really try to look at what the person's needs are going to be, because we're always addressing, right? What is the primary diagnosis that needs treatment? And so generally for people with, you know, dementia, depending on where they are, they may need a nursing home, you know? So we kind of start with that. And so we know that if you're in a nursing home, then you can't be in a pass because it's an exclusive service. So we may start with that, but it becomes real complicated really quickly. You know, we have a lot of people. I was talking to somebody the other day that's been treating people with schizophrenia for a long, long time. And so what he said was, you know, before the life expectancy of someone with schizophrenia was pretty short. They generally passed away before age 60 because of the harsh medications, because of untreated psychosis, because of correlated high or incident of smoking. So, but now we have people with schizophrenia who are living a long time and developing dementia. And so it does become, wait, what are we treating? Are we treating the schizophrenia? Are we treating the dementia? Symptoms look similar across, right? And so I think that's what we try to do, is to work with the medical professionals to say, you know, what is the primary problem? Where's the best place for treatment, and then match people to that. But it is, you know, if you have a family member that's trying to plan for that, it's one of the reasons why we did the PASS and the care coordination, is to try to talk through that, right? As people are aging and they came to us and came to Medicaid because their primary diagnosis was IDD that was before the 22nd birthday, or a mental health condition. Is then how do we best transition them into the next level of care, or have the right services to keep them in maybe a PASS program even as they're elderly. And we do have some people in the PASS program that are you know, 85 or 90.
And that was just my question, because there's a lot of people that need versatile services.
Yeah, that's a good way to put it, is that need versatile services, multiple services. Yeah. Yeah. And so I think that that's one of our challenges, and that may be a good place that you guys want to look at, is that when you're eligible, like at some point, you'd be eligible for 3 waivers, right? Like, right? You would be eligible. You need mental health treatment. You need treatment for diagnosis that happened when you were before age 22, and now you're 70. So how do we make sure that people are getting all the services that they need?
Well, I think, Paula, it goes back to what you said about the PASS model. We do have, and I'm not saying that somebody with a high school diploma and 20 years of experience is not the best to guide me as a special needs parent, versus a PhD doesn't give you the ability to do that. I think it goes back to looking deeply, not just at PASS models, but care management models of, you've got to have somebody, or at least a side-by-side model. I cannot tell you and emphasize more how that nurse has helped me so much with the TBI stuff, what to look for, because I was just lost. And I do have a PhD, but I was completely lost. And resources, transition, you know, do our passes have all that transition of care, of going from, what if your caregiver dies, you know, and you have no one else, you know? I think is that what the pass was set up for, you know, to help transition, you know? Is that kind of what you're talking about? Because we really do need that help, the families do. And again, you always go back to your care coordinator, because they are your advocate.
Do also are involved in my care, but they've never been involved directly physically. I have one parent who is deceased, one parent who is aging, doing the best that she can to help me after she hasn't been taking care of me every day for 15 years anymore because I've been away at college and I came home because I fought ovarian cancer twice and beat it and was in college all at the same time, so I was suggested to come home because everybody wasn't sure about the outcome of my surgery, and everybody thought that I was going to pass away, so I was told to come back and say goodbye to friends and family just in case. And that's after being away for 15 years on my own. And so to kind of throw my family back into this situation when they haven't been directly involved in my care for 15 years is really difficult because not only have I aged and my needs are changing, but my only surviving parent is having aging challenges too, on top of taking care of another person in my family circle that is terminally ill. So that's a lot.
Well, we appreciate your perspective. That's helpful. That's what this council is all about, and I think that helps color, this suggestion. So, I do want to bring us back home because we are running out of time, and we still need to elect our representative for the October meeting. One thing I'll throw out: I think we're at 4 suggestions right now. One of them is regarding the website. You might consider removing that as an official recommendation, and outside of those, we send the website out to the council, you review it, and then we come back the next meeting and have it as a suggestion there.
Okay.
So, but with that, are we good with those 3? I see.
Going back to individuals with acquired disabilities, I would like to ask a question about that specifically. If we can review, if we can create a new waiver or, look at the current waivers to determine if there is like a coding issue, or if.
Well, the coding issue is not at a state level. It's a national level. So there's not anything, am I correct on that? Yeah.
The other thing that came up when I was hearing her question is there are some of us that are our own caregivers and then that are also caring for others, and we need like an extra level of care, so to speak, like I would say not case management from DHS, but maybe have, like, there is a division that's under family services that will come out and help you with referrals as necessary. But I feel like that should kind of be automatic when they know an individual has an acquired or a neurological disability, so we can get the best help we need, like to cover the gaps in services. Like if there is issues like that where we cannot get the therapies we need, to find a way around that.
Like, kind of, how do you guys know that a person with a TBI exists to get them to where they need to go until is that what you're saying? Until we get a waiver? Like, how would you know? Or neurological?
It does sound like this may deserve more discussion. So because we have so little time, I might suggest that we, develop that further and have that at the next meeting.
Yep.
So are we good on the three? Then the last order of business, and we just have a few minutes, is to choose our representative who will attend for the Medicaid Client Voice Council at the October Medicaid Advisory Committee. We already have our three who are going today. Our chair and co-chair will always go, but we have to choose one rotating. So the first question is, does anybody would like to? Amy has volunteered. Is there anybody else who wants to volunteer? Is there anybody?
It's cooler.
All right. Okay, so we have two, so I'll let you each speak briefly about why you'd like to go. I will say, it's rotating, so.
Anyway, now that I know I can listen, I just have to shut up. I'll be just listening.
We'll have an opening at the following meeting too, so. Is there anybody online, Keith? All right, well, since Amy is the only one, you are officially our October representative, and we are officially at the end of our meeting, so thank you all for being here. Appreciate all the perspective, and please get lunch. There's lunch available whether you're going to the later meeting or not.